ممكن نعدل السلايد بس؟ ممكن نحرك الصورة؟ مش معقول كده. هو في مايك؟ السلام عليكم. طبعا المحاضره ديت بنتكلم فيها عن البكتيراليس ميجور تير، وده الكومن ميكانيزم. طبعا نوع من انواع التروما العنيفه اللي احنا بقينا بنقابلها كتير قوي في الايام ديت. هنتكلم فيها عن البكتيراليس ميجور تير. عباره that is a very rare injury. However, in the new trends of bodybuilding and use of anabolic steroid, the rate of pectoralis major tear increased. Most common from 20 to 40 years of old in male, and typically occur in the eccentric mechanism like bench press in 54% of the patient. The tear mostly common being in the lower sternal head. For the biomechanics, we can find that the lower sternal head fibers become at maximum stretch at 30 degree of humeral extension, and that's why it's very common in this kind of injury. The anatomical background, we can find that we have a coastal head, straight head, and it consists about 90% of the mass of that muscle, but the lower sternal head, it consists from 6 to 7 segments, and almost it's around 81% of the mass of the muscle. It's, the nerve supply, lateral pectoral nerve, supply the clavicular head, and the medial pectoral nerve supplying the lower portion of the sternocostal head. Very important to know the orientation of the tendon. So the clavicular, the clavicular head, the tendon is going inferior and lateral. Whatever the sternocostal head, the tendon is going in the back and going superior and lateral. And this is very important as anatomical structure when we look for the repair of this muscle. When we look for the tendon of the big picture is very small tendon. It's around 22 millimeter in length, and the width around 62 millimeter. You can find, we can easily separate the tendon from the medial side, but both the anterior and posterior fibers blend in the back at the insertion side. And we can see here, sorry, you can see how short is the tendon. The tendon part of the muscle is very short. It's around from 2 to 3 millimeter only. Whatever, the collagen fiber of the tendon is continue inside the muscle. And this is very important information also. There is no twisting, it's like card. It's like a splaying of card. There is no twisting on the tendon. It's just like it's tight medially, tight laterally and very narrow medially. According to the common pattern of tear, we can find that the musculotendinous or intertendinous, this is the most common tear type. Whatever the humeral avulsion insertion is very rare, and I never see it before. If we can, of the panel can see it before. We have, when we classify, try to classify the tears, we can find that chronic tear, it represents around 67%, and the acute tear only 33%. For the location, 90% of the tears coming between the musculotendinous junction and the tendon insertion, and most of this tear is partially posterior in 67%, and complete with tear in 73% of this tear. The operative, the tears, we can do an operation for it, mostly the musculotendinous and intertendinous. Whatever the muscle origin tear or the muscle belly is irreparable, we cannot repair that. And for the avulsion of the internal fixation, it needs uri fixation for the avulsed fragment. The timing, if the tear is less than 6 weeks, we consider this an acute tear. If more than 6 weeks, we consider it chronic. The presentation, we can see the ecchymosis around the axillary fold and the upper part of the humerus. One of the missed things is misdiagnosis of these cases is very common because of what we think about the partial tear. Many of the reports for the MRI, they just mentioned that is a partial tear, and that's why a lot of these cases missed. The problem is that mostly the sternocostal head is the tall part, and normally, in most of the cases, the clavicular head is intact. That's why they said it's partial tear. Moreover, the quality of, we have a complete width or incomplete width of the insertion, and this also can contribute to missing of the diagnosis of this kind of cases. The history is very important regarding using the anabolic steroid and the mechanism of action, and the examination of the axillary fold, the ecchymosis, the nipple drop sign, all this clinical criteria of the tear. But also with all of this, it can be missed. So in the most important diagnostic method is the MRI. The coronal views can very easy to follow the sternal head to know exactly which part of the muscle is torn, the clavicular or the sternal head. And in this article, we can find diagnostic method which is called the pectoralis major index. We ask the patient to put his hand in abduction in 90 degree with the elbow flexion 90 degree, and we look for the maximum point of the axillary fold. You can see that point. This point is the maximal curvature of the axillary fold, and we calculate the distance between the nipple, the areola, and that point. When we divide the length of the injured part on the length of the intact part, if we get a score less than 0.9, this indication for pectoralis major tear. So in this case, when we measure the length on the injured part, and on the intact part, we can find that it's 0.67 only. So this is mostly positive for a pectoralis major tear. Now we're looking for the surgical technique. We're starting by defining the coracoid on the lower part of the clavicle. Then we mark the subscapularis immediately below the coracoid. We can imagine that zigzag line. This is mostly the side expectation of our tear should be in this area. And we take a longitudinal axis of the humeral shaft. We sheet little bit medially. We can sheet little bit medially because we need to reach to the retracted pectoralis major muscle, so we can shift our incision little bit to the medial side. It's very important to, sorry, there is a video here, yeah. It's very important to reach to the deltopectoral interval. You will find the cephalic vein retracted laterally, and you need to reach to the right depth. You find the right depth when you find the coracoid and the conjoint tendon, and that level you never cross it because all the nerves is below that level, so this is your maximum area to reach. Then after that, it's very important to know what's intact and what's torn. This is the intact clavicular head. It takes the direction to the insertion. And what's next is still torn. So we need to find exactly which part of the muscle is torn. As we said, not usually completely torn. Then when we define the upper border, we need to start to define the lower border of the muscle. So this is a very important trick. We have here the pectoral fascia. When you do traction on the pectoral fascia, you can find the skin over the pectoralis is moving. And on the junction, here we have the brachial fascia. When you drag it, you find the skin on the upper arm is moving. So that point in the meeting of the brachial fascia and pectoral fascia, no pectoralis major below this level. So this is your lower end. You never need to go down more than this. Then you need to do a proper release for the lower border, and very important to follow the pathological finding. Mostly when you open the fascia here, you will find a seroma. So when you find the seroma, this is indication for the area of the tear. Moreover, you can find the adhesion between the tendon and the brachial fascia. It prevents the tendon to migrate to the insertion. So you need to release this part from lower part so you can drag the muscle to the insertion area. Then you need to define the adhesion between the upper border and the intact head. You can see this is the sternocostal part is torn, and this is the intact part of the clavicular part of the muscle. So we need to release all the adhesion between the upper border of the torn muscle and the lower border of the intact tendon of the clavicular head. So after that, you can withdraw the muscle to the proper insertion place. So it's freely mobile now from lower border and from the upper border from the from the clavicular part of the muscle. Then in the type of the suture, it's very important to know we need to use 2 fiber wire. We use 2 fiber wires in each limb. We suture in log de Krakow method, and we finish by 2 lines, 2 suture. The first one, we call this the endo bottom limb, which with exit from the muscle exactly at the lower border. And the other limb, we call this the bridge limb. So we can make like this a footprint between that point and this point between the 2 tendons. So when we drag it to the insertion, we have a footprint, not only line, it will be like a space of 2 millimeter to get proper adhesion with the insertion side. Then we go after that, after we finish, we have a double fiber wire here and here. So we finally end by 4 suture from here and 4 suture from the upper limb of the muscle. And this is the final picture. You can imagine how much you can drag. This lower fiber, it's almost 80% of the size of the muscle. So the costal head, even you cannot notice how much the clavicular head can make of the side of the muscle, but the lower part is a major. So we don't consider the torn sternal costal muscle is a partial tear. It's almost, most of the muscle is torn. Then we go for the preparation of the footprint. We go to the for the intertubercular notch. You need to define the biceps tendon here and the conjoint tendon. So you will put 1 human to the medial side to protect the conjoint tendon and the biceps. This is the conjoint and this is the biceps. You will put your human here to retract them and protect the musculoskeletal nerve. And the other human on the lateral side, you will take the part of the intact tendon, because we still have the clavicular head is still intact, so you need to protect that tendon. You will put that human to take the intact tendon to the other side. Then you will start your preparation for the footprint, open the periosteum and start to scratch it by the curettage to make a surface for healing of the tendon. Then we do our drill holes. The only trick in the drill holes, you will measure the distance between the 2 sutures, so you will know the width of your graft. And when you do this drill, try to go little bit oblique in the upward direction, because if you go directly 90 degree, sometimes you cannot flip the endobottom, because sometimes you reach to the other cortex and you are not able to flip the bottom. So try to take the drill holes little bit oblique, so it will be easier for you to flip the bottom. This is how we do the bottom. There is a small trick on that. You will pass the suture from down, then rotate it 90 degree and turn the other bottom from here. You can see the beveled edge of the endobottom. That beveled edge is very important on the direction when you go down inside the hole. You need that, like the front of the ship. You need that beveled area to hit the posterior cortex of the humerus, so it will help you in the flipping of the endobottom. As you can see here, we do traction on these sutures, and we go in that direction. Then when you go inside the hole, that beveled part will hit the posterior cortex, and in the same time you will do traction on these fibers, so you can flip the endobottom is easier. Then this is after we putting the 2 endobottom. So you can notice that we have the bottom limb, as we said, and this is the bridge limb. If you have a confusion between these 2, you can find that the bottom limb, when you make a traction on it, it will grasp the tendon toward the bone. But if you grasp the bridge limb, it will take it out. So it's easy for you to differentiate between them if you're lost in the middle. Finally, when you need to tight your suture in neutral position, and in the same time it allows little bit of external rotation and abduction to 30 degree. And this is the picture after we reconstruct the axillary fold completely, And this is the apex of the axilla here. You can see that we correct all the sternal head, we take it all part of it, and then we ensure that the abduction can reach to up to 30 degrees of abduction and external rotation. The rehabilitation protocol is first 3 weeks in the sling, and then from 3 to 6 passive range of motion, and from 6 to 12 we initiate in the active range of motion, and the strengthening exercise it will be from 12 to 16 weeks. When we have a tight or chronic case, we use a modified protocol. We delay around 2 weeks in each step to give more protection for our repair. When we have a chronic tear, also most of the chronic tear can be repaired directly from the start. Still, some of the cases become very difficult because the loss of collagen due to the muscle atrophy, so we need some time to use an graft to reconstruct the insertion. So we either use the dermal graft or the allograft like tendo Achilles. The good benefit with using the dermal graft is cellular graft, so we can use the cellular dermis to give more strength for the repair and proper power of healing at the insertion site. This is the technique how we use it, described in this paper. You will fold the dermal graft and make a suture in the middle, so it will be like that. And finally, we put the tendon in this area, and we close it on the tip of the muscle. يعني زي المشبك بالظبط كده، كأنك بتركب مشبك على طرف المصل بالظبط. This is the part not working anymore. This is the part we use it. The other end we use it to fix it to the insertion site. And this is the picture after we do the repair. You can see this is the graft, this is the musculotendinous part, and this is the dermal part. We continue by our suture little bit more in the muscle, then we reconstruct it like that in the same position. And this is the other paper by Abdullah Hashim, how he using the tendo Achilles graft instead in the massive tear. So as we can conclude at the end, the outcomes of the repair is very superior to conservative treatment. So no rule in the meta-analysis now for using just conservative treatment unless the patient old age, he has simple work, because the result of repair, if you have up to 90% of the patient can return to sport, and 74% can return to the normal level before the injury. Most of the patient experience complete pain relief, and also the cosmetic appearance is improved in most of the patient, and the complication rate in maximum of the paper around 7%. The complication like infection or re-rupture, it is the main type of tear. Thank you.
في أي أسئلة دكتور أحمد قبل ما ننقل على الجزء الثاني من السيشن؟